Hi friends, welcome back to the channel. Today we are going to discuss an important topic from endocrinology, that is Mann syndromes. Now these syndromes are although rare in clinical practice, but various questions can be asked in different exams. So let's see what all questions you will be able to answer after completion of this lecture. Most common pituitary adenoma associated with MEN1 is prolactinoma, somatotrophinoma, corticotrophinoma or non-functional. So this is basically a one-liner question which can be asked. Then some clinical questions can be asked, like a 32-year-old man who presents to your OPD with complaints of recurrent episodes of weakness, headache, sweating and fainting, especially after fasting. He tells that symptoms improve after food intake. So basically these are the symptoms of hypoglycemia. There is history of MEN1 syndrome running in the family. Serum C peptide levels are found to be elevated. This confirms the excess insulin, which can be due to insulinoma. So what is the definitive treatment in this patient? So basically they are asking the treatment of insulinoma in MEN1. So we will be able to answer all these questions. And let's see another question. A 35-year-old male patient is referred to you with features of parathyroid adenoma and testicular tumor. While going through the reports, you see a genetic report showing mutation in CDKN1B gene. What is the most likely diagnosis? So we will also discuss the various mutations which are seen in MEN1, MEN2 and MEN4 syndrome. So let's start with the lecture. So what does MEN stands for? So MEN means multiple endocrine neoplasia. Multiple endocrine neoplasia. So these syndromes will have tumors of various endocrine glands. This is the common feature of all MEN syndromes. So these syndromes are characterized by a predilection for tumors involving two or more endocrine glands. There are four major forms of MEN which are recognized, and these are MEN1 to MEN4. So basically we have MEN1, then MEN2, which is divided into two, MEN2A and 2B. Now this MEN2B is considered as MEN3, and finally we have MEN4, which is very similar to MEN1 except for the mutation and some clinical differences which we will discuss in this presentation. Now it is important to note that each of these MEN syndromes are inherited as autosomal dominant, or these can be sporadic without any family history. Now this point is very important because some students consider that these MEN syndromes are always genetic, but these can be sporadic as well. Now in addition to these four types of MEN, there are 6 other syndromes which are associated with multiple endocrine and other organ neoplasias. So other than endocrine tumors, the tumors of other organs can also be seen, and these are therefore known as MEON syndromes. MEON stands for multiple endocrine and other organ neoplasias. So we will discuss this syndrome in detail in a separate lecture. For now, just remember there are 6 types which include hyperparathyroidism, jaw tumor syndrome, then there is Carney's complex, von Hippel-Lindau disease, neurofibromatosis type 1, Cowden syndrome and McCune-Albright syndrome. Just remember that all the MEN syndrome and MEON syndromes are autosomal dominant except for McCune-Albright. Except for McCune-Albright, which is due to post-zygotic mosaic mutation of GNAS1 gene and GS alpha protein. So all the MEN and MEON are autosomal dominant except McCune-Albright syndrome. Now how can we diagnose these MEN syndromes? So a diagnosis of MEN or even MEON syndrome may be established in an individual by any one of the 3 criteria. What are these criteria? The clinical features, that is more than equal to 2 associated tumors or lesions, familial pattern in a first degree relative, the presence of similar clinical disease in the first degree relative in the family, or genetic analysis showing the germline mutation in associated gene in an individual who can be either symptomatic or asymptomatic. So even in asymptomatic individuals, we can identify this Mann syndromes by genetic analysis. So what is the role of genetic testing in Mann syndrome? Firstly, to confirm the diagnosis in a person who is suspected of this syndrome due to the clinical features. Then in a person who is diagnosed with Mann syndrome, his family members need to be identified. So identification of family members with mutations. So these testing are basically done in first degree relatives, which we have discussed. So if this genetic testing is positive, these patients will require screening for tumors so that early treatment can be started. This second indication is very important, and third is also very important. Nowadays what happens is patient Googles everything about his disease. Now once you have established a diagnosis of Mann syndrome in any patient, he will come to know that this condition runs in families. So this third role is very useful. So we have to importantly identify the family members who do not have the mutation. So 50% of the family members will not have this germline mutation. This will alleviate the anxiety of the family members as well as patient, and it will also decrease the health care cost by reducing the need for unnecessary biochemical and radiological investigations for various tumors. So we discussed that we have four types of Mann syndrome. We have Mann 1, Mann 2, which is divided into Mann 2A and Mann 2B. Mann 2B is also known as 3, and then Mann 4 syndrome. Now let's discuss the individual Mann syndromes one by one, starting with the Mann 1. So Mann 1 is also known as Wermer syndrome, and it is characterized by triad of tumors. We can easily remember this by 3 P's. So that is parathyroid, pancreatic islets, and anterior pituitary. So these form the major criteria. At least these should be positive. 2 out of 3 should be positive for diagnosis to be considered. Now other tumors which are not necessarily present in Mann 1 syndrome include adrenocortical tumor, carcinoids, meningiomas, facial angiofibromas, cholangiomas, and multiple lipomas. These are positive or present in some patients. Now it is important to note that this Mann 1 is non-familial or sporadic in about 10% of the cases. So for these patients, genetic testing will come out to be negative in family members. First degree relatives will have no genetic mutation. Now when we consider the individual major criteria and its association with Mann 1, so primary hyperparathyroidism is associated with 1 to 18% prevalence of Mann 1. So if we take 100 patients of primary hyperparathyroidism, 1 to 18% will be associated with Mann 1 in according to the various studies. Pancreatic islet cell tumors are associated with 16 to 38% prevalence, and then pituitary tumors are associated with less than 3% of the prevalence. Now these pituitary tumors, especially if these present in less than 20 years of age, we have to consider the diagnosis of genetic syndrome like Mann 1, or it can be due to McCune-Albright syndrome or Carney's complex. So young age of presentation of pituitary tumor suggests the diagnosis of a genetic syndrome associated with the tumor. Now disorder can present in any age group, but the most common presentation is in the 5th decade. In the absence of treatment, this is associated with high mortality. What is the mortality? There is 50% probability of death by 50 years of age in Mann 1 syndrome. What is the most common cause of death? Out of the 3 P's, it is pancreatic neuroendocrine tumors. We'll discuss all the tumors in detail. Just these are some one-liner questions that most common cause of death in Mann 1 syndrome are pancreatic neuroendocrine tumors. Although these are benign tumors, in men 1, but still these are the most common cause of death. Now, these tumors in men 1 are also associated with occult metastatic disease. These are large tumors in men 1. These are more aggressive and resistant to treatment if we compare it with the tumors that occur in isolation. So the same tumors which are associated with men 1, if these are associated with men 1, will have poor prognosis as compared to the isolated tumors. Now let's come to the individual manifestations of men 1. So as we have discussed, the three major manifestations are 3 P's, that are involvement of parathyroid gland, most commonly parathyroid hyperplasia. This is seen in more than 90% of the patient and it is the most common manifestation. Then pancreatic neuroendocrine tumors. These are seen in 30 to 70% of the cases of men 1 and it is the most common cause of death in men 1. And finally, anterior pituitary tumors. These are seen in 15 to 50% of the patients in various case series. Now we'll discuss these 3 P's in detail and we'll just discuss some important points about the rare tumors seen in men 1. So primary hyperparathyroidism occurs in about 90% patients of men 1 and it is the most common feature associated with this syndrome. Now patients can have asymptomatic hypercalcemia due to increased PTH but can also present with vague symptoms. What are the symptoms of hypercalcemia? These can be polyuria, polydipsia, constipation, malaise or dyspepsia. So these are some of the vague presentations of hypercalcemia. Rarely patient can also present with severe abdominal pain. So let's discuss a clinical case. A young male presented with severe abdominal pain in emergency department. When you take history, there is history of renal calculi. This renal calculi can be due to hypercalcemia and hypercalciuria associated with increased PTH. So if this history of renal calculi is there, you do ultrasonography, but ultrasonography does not reveal any renal calculi, have no gallstone. This patient is the medical cause of acute abdomen. Medical cause of acute abdomen. When you do ABG in such patient, if hypercalcemia is seen, then it is most likely due to pain due to hypercalcemia. So rarely acute abdominal pain can also be there due to hypercalcemia. So it is important to note that what are the medical causes of acute abdomen. Firstly, myocardial infarction, especially inferior wall MI can also have acute abdomen, pain abdomen. So always do a ECG in such patients. Metabolic acidosis. So patients of diabetic ketoacidosis typically present with nausea, vomiting and abdominal pain. Then lead poisoning can lead to abdominal pain. Hypercalcemia we have discussed, and rarely acute intermittent porphyria can also lead to acute abdomen. Now what is the difference in hyperparathyroidism which is associated with men 1 versus without men 1? So men 1 has early onset of hyperparathyroidism, that is if it is present less than 25 years of age, consider men 1. On the other hand, without men 1 there is late onset at around 55 years of age. Now female to male ratio. Female to male ratio without men 1 it is more common in females, 3:1, but in men 1 this female to male ratio is equal. So most of the patients will present before 25 years, but at 40 years, almost all the patients, 100% patients of men 1 will have this hyperparathyroidism. Now what is the management of hyperparathyroidism in men 1? So firstly, the investigation is Sestam-AB scan. This scan shows asymmetrical involvement of all the 4 parathyroid glands in the form of hyperplasia. So the definitive treatment is surgical removal. We go for total parathyroidectomy, and minimally invasive approach is not recommended as all the 4 glands are affected. What if surgery is not possible, or there is contraindication to surgery, or patient is unfit for surgery? Do we have any medical treatment? Yes, a drug known as cinacalcet, which is a calcimimetic drug. How does this drug act? It acts via calcium sensing receptor on parathyroid cells. It increases the sensitivity of calcium on this receptor, and by negative feedback, this will decrease the parathormone levels. So cinacalcet can be used in such patients in which surgery is contraindicated, patient is unfit for surgery, or if surgery is done, it is unsuccessful. Now coming on to the second major manifestation of Mann syndrome, that is second P, which stands for pancreatic tumors. So basically these are enteropancreatic neuroendocrine tumors. So what are neuroendocrine tumors? Which produce excess of hormone. So these are hormone secreting tumors. As we discussed, these are the second most common manifestation after hyperparathyroidism, and these are present in 30 to 80% of patients in different case series. Now similar to parathyroid hyperplasia, pancreatic neuroendocrine tumor also have earlier age of onset in patients of MAN1. Now these pancreatic neuroendocrine tumors can secrete various hormones, like there can be gastrinoma, there can be insulinoma. These tumors can secrete glucagon, or these rarely can secrete VIP, and some tumors are non-functioning or producing pancreatic polypeptide known as PPO. Now out of these all pancreatic neuroendocrine tumor, most common is gastrinoma, which comprises more than 50% of the all neuroendocrine tumors, that is pancreatic neuroendocrine tumors associated with MAN1. What is the investigation of choice for these tumors? It is somatostatin receptor scintigraphy, but for small tumors and multifocal tumors, endoscopic ultrasound is better. For small and multifocal tumors, endoscopic USG is better. Now let's discuss some few important points of these individual neuroendocrine tumors, starting with gastrinoma. So these gastrinoma are gastrin secreting tumors which are associated with marked increased gastric acid production with recurrent peptic ulceration. So increased production of gastrin will lead to increased gastric acid production, which will lead to recurrent peptic ulcer. This is the common presentation of the patient of gastrinoma, and this combination is known as Zollinger-Ellison syndrome. So direct question can be asked that Zollinger-Ellison syndrome is a presentation of gastrinoma. Now in MAN1, gastrinoma occurs usually after 30 years of age. The diagnosis is established by demonstration of increased fasting gastrin leading to increased basal gastric secretion. Now for imaging, we can go for ultrasonography, endoscopic ultrasonography, CT, MRI, but as we have discussed, the investigation of choice is somatostatin receptor scintigraphy, because this is helpful in localizing the tumor prior to surgery. It is the most common neuroendocrine tumor, and it is more than 50% of all pancreatic neuroendocrine tumors in MAN1. Now when we talk otherwise, 20% of the gastrinoma have MAN1. So this is so common in MAN1 that if we take 100 patients of gastrinoma, 20 will have MAN1 syndrome. Now this is a very important question which can be asked. What is the difference between gastrinoma which is sporadic and the one which is associated with MAN1 syndrome? So sporadic gastrinoma always occurs in Passaro's triangle. This is also known as gastrinoma triangle. It has 3 boundaries. First is cystic duct, second is junction of neck and body of pancreas, and third is junction of second and third part of the duodenum. So there will be formation of this triangle in which the gastrinoma will arise. On the other hand, MEN1 gastrinoma is usually duodenal in origin, occurs in 20 to 40 years of age group. We have discussed more than 30 years of age group. It is associated with recurrent and refractory peptic ulcers. High dose PPI therapy is required. If the size is more than 2 cm, we go for surgery. For malignancy, we can use somatostatin analogs like octreotide, lanreotide, and for chemotherapy, we can go for streptozotocin, which we will discuss in next slide. The sporadic gastrinoma is usually unilocular and single, while MEN1 gastrinoma is multilocular and multiple. Sporadic has blood-borne spread, while MEN1 gastrinoma has lymph node spread. Now, it is very important to note that although the tumors which are associated with MEN1 have higher risk of metastasis, these are more aggressive as compared to the isolated tumors, but this gastrinoma, when it is associated with MEN1, has less than 5% risk of malignancy, while the sporadic gastrinoma has 50% risk of malignancy. Although it is associated with less than 5% of malignancy, but still it is the most common cause of death in MEN1. So we discussed that pancreatic neuroendocrine tumors are most common cause of death in MEN1 syndrome. Coming on to the treatment of gastrinoma. So medical treatment of patients with MEN1 and Zollinger-Ellison syndrome is directed towards reducing the basal acid output to prevent the peptic ulceration. Often both proton pump inhibitors like rabeprazole, omeprazole, and H2 receptor blockers like ranitidine need to be combined for effective acid suppression. But if someone asks drug of choice and both are given in options, then we have to choose proton pump inhibitor as drug of choice, as it leads to more aggressive reduction in gastric acid output. Now, what is the role of surgery in MEN1? So for pancreatic neuroendocrine tumors, the surgery is controversial because once the tumor becomes more than 2 cm in size, there is lymph node metastasis, and after 4 cm, there is hepatic metastasis. However, surgery for such patients is recommended even when the size becomes more than 2 cm, and specifically for duodenal gastrinomas have been treated effectively in most of the studies by surgery. So role of surgery in gastrinoma is if size is more than 2 cm or if there is duodenal gastrinoma, which is the most common site of gastrinoma in MEN1. Medical therapy includes chemotherapy with streptozotocin, chemotherapeutic drugs like streptozotocin, 5-fluorouracil, and we also need to suppress the hormone with somatostatin analogs like octreotide, lanreotide, and pasireotide. Now, in some patients, we can also try radiotherapy, specifically if the disease has metastasized. So, various modalities of radiotherapy include selected internal radiation therapy, which is known as SIRT. Then we can go for radiofrequency ablation, or we can go for peptide radioreceptor therapy. Now, these radiotherapy and most of the chemotherapy will be common to the various type of pancreatic neuroendocrine tumors, which we'll discuss. Now, second most common pancreatic neuroendocrine tumor is insulinoma, which is the tumor of beta cell of pancreas. This is coming from the beta cells of pancreas. So it is responsible for 10 to 30% of all the neuroendocrine tumors in MEN1. Patient presents with weakness, fatigue, faintness, seizures, altered behaviors. So all these features are due to hypoglycemia, which is associated with increased insulin levels. And as we all know, insulin is an anabolic hormone. So patient also have history of weight gain, as insulin is anabolic. Now, when we do biochemical investigation, it will reveal increased insulin concentration in association with hypoglycemia. Also, there will be increased C-peptide levels, as this is the endogenous insulin axis. Now, insulinoma in contrast to gastrinoma, which is, we discussed that gastrinoma occurs in more than 30 years of age, while insulinoma is associated with early age of onset in men 1, and some patients can also present less than 20 years of age. So this may be the first manifestation of the man 1. So if a young patient, typically a young boy, presents at the 15 years of age with weakness, fatigue, faintness, and then testing you find hypoglycemia associated with increased insulin levels, increased C-peptide. So always consider this diagnosis. When we consider all the patients of insulinoma, 4% are associated with men 1. Now what is the treatment? Surgery is the optimal treatment. Medical management includes somatostatin receptor analogs like octreotide. Diazoxide can be used. Now this drug is used specifically in insulinoma because this inhibits the insulin release. Patient is also asked to consume frequent carbohydrate meals to prevent hypoglycemia. Frequent carbohydrate meals rich in glucose are advised. Then for chemotherapy, again we go for streptozotocin 5-fluorouracil. We can also go for peptide radioreceptor therapy. Coming on to glucagonoma, these are very rare tumors. These are seen in only less than 3% patients of man 1. Surgical removal is the treatment of choice. Rest of the treatment is similar, that is we can go for somatostatin receptor analogs, we can go for chemotherapy, again streptozotocin 5-fluorouracil and radiotherapy, etc. VIPoma is even rare, which is seen in less than 1% patients of man 1. Important question is WDHA syndrome. What is this WDHA syndrome? This acronym stands for watery diarrhea, hypokalemia, and achlorhydria. So this stands for WDHA syndrome. This can be an important question associated with VIPoma. This is also known as Werner-Morrison syndrome. For diagnosis, we have to exclude the laxative use, diuretic abuse which can lead to hypokalemia. Stool volume should be 500 ml to 1000 ml per day even during fasting, and biochemical investigation should reveal increased VIP levels. Treatment is similar. Surgery is the treatment of choice, and we can also go for medical management in unresectable cases. Now next neuroendocrine tumors are pancreatic polypeptide secreting tumor, which are known as PPOMAs, and some non-functioning pancreatic neuroendocrine tumors. So these tumors comprise 20 to 55% of all the neuroendocrine tumors associated with man 1, but still we are discussing these in last because there is no pathological sequelae of excessive polypeptide secretion which are apparent. So absence of clinical features and specific biochemical abnormalities may result in delayed diagnosis of PPOMA and non-functioning tumors, and this is the reason why these neuroendocrine tumors have a worse prognosis than functional tumors like insulinoma, gastrinoma, etc. So for identification, most sensitive technique is endoscopic ultrasound, which can detect even small pancreatic neuroendocrine tumors, but most reliable, that is investigation of choice, we have already discussed, is somatostatin receptor scintigraphy, because this can also detect distant metastasis, and we have to do this before the surgery to know the exact location of the tumor. So for treatment, we go for surgery if the size is more than 2 cm. We can also use tyrosine kinase inhibitors and mTOR inhibitors for the metastatic disease if the surgery is not possible. Again, radiotherapy similar to the other neuroendocrine tumors can be used. Now, other than these PPOMAs, non-functioning pancreatic neuroendocrine tumors, there are some rare tumors which can secrete growth hormone releasing hormone, which can result in acromegaly in man 1 syndrome. Although acromegaly is also a manifestation which can occur due to pituitary adenoma secreting growth hormone, this can also lead to acromegaly. Very rarely there is somatostatin secreting tumor, which can present with hyperglycemia, cholelithiasis, weight loss, etc. So till now, we are discussing MEN1. MEN1, we have discussed that the major manifestations are 3 Ps and there are some minor manifestations. We are discussing the major manifestations. First, we have discussed the involvement of parathyroid, and secondly, we have discussed the second P, that is pancreatic neuroendocrine tumor. In pancreatic neuroendocrine tumors, we have discussed gastrinoma, then we have discussed insulinoma, glucagonoma, VIPoma, PPomas, and non-functioning neuroendocrine tumors. Now we will go on to the third P, that is anterior pituitary tumors. So the third P is pituitary tumors. So the most important point is that there is involvement of only anterior pituitary in MEN1 and there is no involvement of posterior pituitary. But still diabetes insipidus can occur in MEN1. We will discuss how. So 15 to 50% patients of MEN1 have pituitary tumors. These are mostly microadenomas, that is less than 1 centimeter in diameter. So microadenoma is less than 1 centimeter, macroadenoma is 1 to 4 centimeter, and giant adenoma is more than 4 centimeter. So in 75% of the cases, these are microadenomas. These are more common in females than males, but if males are involved, the risk of macroadenoma is more. Males commonly have macroadenoma. Now, among the hormones secreted, most commonly we have prolactin secreting adenoma, which is seen in 60% of the cases. Then growth hormone secreting adenoma, which is around 25%. Then ACTH secreting adenoma, which is 5%. Rest 10% are non-functional adenomas, non-functional tumors. Patients with anterior pituitary tumors, when we consider, 3% of them will have MEN1. So what are the features suggestive of MEN1? When there is early age of onset less than 20 years. So if anterior pituitary tumors are occurring in less than 20 years, we have to consider MEN1, McCune-Albright syndrome, and Carney's complex. So these are the genetic syndromes associated with anterior pituitary tumors. Now coming on to the clinical features. So firstly, the patient can be asymptomatic or can have hormonal effects, mass effect, or stalk effect. We will discuss them one by one. So hormonal effect of prolactin secretion, prolactin hypersecretion in females can be amenorrhea, galactorrhea, and infertility. Basically, these patients usually present with secondary amenorrhea. In males, this increased prolactin level can lead to impotence and infertility. Growth hormone excess will lead to acromegaly, and ACTH excess will lead to Cushing's disease. Now, what is this mass effect? Mass effect is usually seen with macroadenomas. This will lead to raised ICT, which can produce headache, vomiting. This can go and hit optic chiasma, which can lead to bitemporal hemianopia. Cavernous sinus, which is laterally related to pituitary, that can be invaded by the tumor, which can involve sixth nerve, internal carotid artery, third nerve involvement can be there, fourth nerve, fifth nerve. All these nervous involvements can be seen with the mass effect. Now, what is stalk effect? So, stalk effect is important to understand. So, suppose this is hypothalamus, this is the stalk, this is the anterior pituitary, and this is the posterior pituitary. Now, if a tumor is arising out of anterior pituitary, what happens is these tumors become so big that it leads to compression of the stalk. Now, due to this compression of the stalk, the hypothalamic releasing factors which were coming to anterior pituitary, these cannot come now, and the ADH and oxytocin which was coming to the posterior pituitary, this also cannot occur as stalk is compressed. So this stalk effect can lead to panhypopituitarism, as well as diabetes insipidus. So diabetes insipidus in MEN1 syndrome can occur due to this stalk effect and not due to the involvement of posterior pituitary. Now, how will we monitor these tumors and what is the treatment? So for monitoring of asymptomatic MEN1 patients, we have to go for periodic testing. We basically measure serum prolactin, insulin like growth factor 1 levels. Basically growth hormone cannot be measured directly. It has a very short half-life, and measuring it directly will lead to erroneous results. So we go for IGF-1 measurement, and MRI brain can also be used for detection and measurement of the size of the tumor. So these basically lead to the early identification of these tumors in MEN1 syndrome. For treatment, we have to go for surgery in most of the cases. What is the approach used? It is transsphenoidal approach. For medical management, for prolactinoma, what we can do? We can give dopaminergic agonists like cabergoline and bromocriptine. Bromocriptine is used especially in the pregnancy. While for growth hormone secreting adenoma, we have to give somatostatin receptor analogs like octreotide, lanreotide, etc. Also, we can give growth hormone receptor antagonist like pegvisomant. Basically, the surgery is the treatment of choice for any kind of tumor. Now, after we have discussed the 3 P's of MEN1, we will discuss some important points about other tumors which are found in this syndrome. So basically, we will discuss some adrenal tumors, carcinoid tumors, lipomas, angiofibromas, few points about cholangioма and meningioma. So adrenocortical tumor in MEN1 are usually asymptomatic, although these are found in 20 to 70% patients of MEN1 according to the various case series. Now, most of these are cortical adenomas, hyperplasia, cyst, and carcinoma are only seen in less than 1% of these cases. Carcinoma are only seen in less than 1%, and most of them are benign. Now, it is important to note that these adrenocortical cortical tumors are non-functional in most of the cases. Now, can adrenal medulla be affected in MEN1? So yes, pheochromocytoma, although very rare, less than 1% cases of MEN1, but it can be seen in this syndrome. Now, as we have discussed, majority of these tumors are benign, that is adrenocortical tumors are benign, but risk of malignancy is directly proportional to the size. Therefore, surgery is considered when the size is more than 4 cm in diameter, or if the size is 1 to 4 cm, but the patient is having suspicious radiological features, typically increased hypodensity on the unenhanced CT. You go for the CT abdomen and there is hypodensity in the adrenal mass. Or if there is significant growth over 6 months, we can also go for surgery. Coming on to carcinoid, these occur in more than 3% patients of MEN1. These can arise from bronchus, GIT, pancreas or thymus. These are usually asymptomatic. These carcinoids in MEN1 are also asymptomatic. That is, there is no hormonal or biochemical abnormality associated with these tumors. So, since there are no biochemical abnormalities, we cannot screen by a blood test. We have to do radiologic imaging for the screening of these tumors. So, gastric carcinoids are seen in more than 10% patients of MEN1, and these are usually multiple as compared to that of sporadic gastric carcinoid. Bronchial carcinoids in MEN1, just important point is that it is more common in females, while thymic carcinoids are much more common in males. That is ratio of 20:1. These are associated with smoking and have aggressive course in MEN1. Thymic carcinoids have aggressive course in MEN1. For all these carcinoids, surgery is the treatment of choice and medical management is similar. That is, we can go for chemotherapy, somatostatin receptor analogs and radiotherapy. Then meningioma are seen in less than 10% patients of MEN1. These are also usually asymptomatic. Subcutaneous lipomas occur in more than 33% patients, and these are frequently multiple. So these multiple subcutaneous lipomas, then facial angiofibromas, collagenomas, which are present in more than 50% of the patient. These cutaneous findings basically can allow us to diagnose MEN1 in pre-symptomatic phase. So pre-symptomatic diagnosis of MEN1, especially in the family members of the patient of MEN1, is easy via these skin markers like lipomas, facial angiofibroma, and collagenomas. These should never be missed in the family member of the patient with MEN1. Now, thyroid tumors, some studies have suggested thyroid tumors can be associated with MEN1, but since the prevalence of thyroid disorders in general population is also high, therefore we can say that association with MEN1 may be incidental. This is the image showing facial angiofibromas and nasal angiofibromas in patient with MEN1. Now let's discuss some important points about the genetics of MEN1. So MEN1 gene is present on chromosome number 11q. It encodes a protein which is menin. Now this menin is a tumor suppressor gene which regulates transcription, genome stability, cell division and proliferation. Now the pathophysiology of MEN1 follows Knudsen 2-hit hypothesis. So in a person with a germline MEN1 mutation, if there is second hit in the form of somatic mutation, which is most commonly a deletion, or rarely this can also be a intron inversion. Most commonly this somatic mutation is a deletion. This 2-hit leads to predisposition of tumors since the tumor suppressor gene gets inactivated. Now some families with MEN1 mutations develop parathyroid tumors as the sole endocrinopathy, and this condition is referred to as familial isolated hyperparathyroidism, or in short FIHP. So this is a condition in which there is familial hyperparathyroidism association with MEN1 syndrome, that is mutation in MEN1 gene. In this condition, no other tumor manifestation will be seen. So the current guidelines recommend that MEN1 genetic testing should be done in an index case which has 2 out of 3 major MEN1 tumors, that is out of 3 Ps if 2 are present, parathyroid, pancreatic neuroendocrine tumors, anterior pituitary. If any 2 are present, we have to go for genetic testing. First degree relatives of a known MEN1 mutation carrier will have to undergo genetic testing, and a patient who is highly suspicious of MEN1 even with only one manifestation. So if a patient is having parathyroid manifestation less than 30 years of age, or if the patient is having pancreatic neuroendocrine tumor at any age, or a patient having pituitary adenoma as we discussed less than 20 years of age, these patients should also undergo genetic testing. Obviously, these have to consider for testing in the clinical context, especially if these are associated with other minor manifestations like angiofibromas, multiple lipomas, meningioma, etc. With this, we have completed our discussion on MEN1. Now coming on to MEN2. So first of all, MEN2, we have divided MEN2 into MEN2A, which is also known as, which is considered as MEN2, then MEN2B, which is also considered as MEN3, and there is entity known as medullary thyroid carcinoma only syndrome, also known as familial medullary thyroid carcinoma syndrome. So the common feature between MEN2A and MEN2B is that both of this will have medullary thyroid carcinoma in more than 90% of the cases and pheochromocytoma in more than 50% of the cases. This is the common feature between 2A and 2B and the differences which we'll discuss in the slides. So first we will discuss MEN2A. It is also known as Sippel syndrome. We discussed MEN1 is also known as Wermer syndrome. MEN2A is known as Sippel syndrome. It is characterized by association of medullary thyroid carcinoma in almost 100% of the cases, pheochromocytoma in 50% of the cases, and parathyroid tumors in 20% of the cases. So this triad comprises of MEN2A syndrome. Now when we consider the variants of MEN2A, we have classical MEN2A which have these 3 features, then MEN2A with cutaneous lichen amyloidosis, and MEN2A with Hirschsprung disease. So MEN2A with Hirschsprung disease is caused by absence of autonomic ganglia cells in the terminal hindgut, which leads to colonic dilatation, obstruction, and severe constipation. So these are the three variants of MEN2A. In MEN2, we discussed that there is a condition known as familial medullary thyroid carcinoma syndrome or MTC only syndrome. It is different from MEN2A. How? If more than equal to 4 family members are there with only medullary thyroid carcinoma, but without any pheochromocytoma, without any parathyroid involvement, this is considered as FMTC variant. This is considered as FMTC variant, but on genetic testing, there will be mutation in the red proto-oncogene, which we will discuss later. Then MEN2B, also known as MEN3, it is responsible for 5% of all the MEN2 cases. In this, the first two manifestations are same, that is medullary thyroid carcinoma in almost 100% of the cases, pheochromocytoma in 50% of the cases. Now, instead of parathyroid involvement, there are 4 M's which are seen in MEN2B. These stands for Marfanoid habitus, feature similar to Marfan syndrome. Then mucosal neuromas, especially of lips, tongue, eyelids. Then medullated corneal fibers, involvement of eye in the form of medullated corneal fibers. And finally, megacolon. So megacolon is again due to intestinal autonomic ganglion dysfunction. So do not confuse this, guys, that MEN2A can also be associated with Hirschsprung disease, which can lead to megacolon, and MEN2B has the manifestation in the form of 4Ms, and the one out of this 4M is megacolon. Now, genetics of all the MEN2 syndrome, including 2A, 2B, and medullary thyroid carcinoma only syndrome, there is mutation of RET proto-oncogene. RET proto-oncogene, which codes for tyrosine kinase receptor. Now, it is important to note that there is correlation between the location of mutation and the syndrome produced. So, we'll discuss that which mutation is seen commonly in MEN2A, which mutation is seen in MEN2B, and which mutation is seen in MTC only syndrome. This location of mutation will decide that which syndrome the patient will develop. Now we will individually discuss the 3 major manifestations of MEN2, that are medullary carcinoma of thyroid, pheochromocytoma, and parathyroid involvement. So, most common feature of MEN2A as well as MEN2B is medullary thyroid carcinoma, and it occurs in almost all the affected individuals. So, almost 100% of the individuals affected with MEN2 will have this manifestation. Now, earlier we used to see the patients with symptomatic tumors. Earlier, the patients with medullary thyroid carcinoma presented with some symptoms, but now due to genetic testing of family members, the presentation has shifted to the preclinical disease, which is identified on the genetic screening of the family members. Now, this is very good as we can go for prophylactic thyroidectomy, because this tumor, if occurs, is associated with poor prognosis. When we consider 20% of the medullary thyroid carcinoma patients are associated with positive family history. There is positive family history in almost 20% of MTC patients. Now, in sporadic cases, patients may present with palpable mass in the neck, which may be asymptomatic, or there can be some symptoms associated with pressure or dysphagia. Patient can present with diarrhea in 30% of the cases, which is associated with elevated levels of calcitonin, or there can be tumor related secretion of serotonin and prostaglandins. This serotonin can also lead to flushing experienced by some patients of medullary thyroid carcinoma. Now there can be ectopic ACTH secretion by this cancer, which can lead to Cushing syndrome. Features of Cushing can be there in these patients. Now the diagnosis of MTC relies on demonstration of basal calcitonin levels more than 90 picogram per ml or nanogram per liter. For confirmation, we go for neck ultrasonography with FNAC. Now this MTC can have aggressive clinical course with early metastasis and death in 10% of the patients. So what are the sites of metastasis? It can metastasize to cervical lymph nodes, lung, liver, then there can be mets to esophagus, and late stages can also metastasize to bone. Coming on to the treatment of MTC. So asymptomatic patients who are identified with RET mutations have to undergo prophylactic surgery even before less than 1 year in some patients up to 5 years of age. Now this age of surgery will depend on the type of RET mutation, which decides that what is the growth of the tumor, what is the rate of metastasis of the tumor. So depending on the mutation, the age of surgery is 1 to 5 years. Even before 1 year, some have to undergo surgery. Which surgery is done? Total thyroidectomy. So prophylactic thyroidectomy has to be done, and the patient have to take lifelong T4. Lifelong T4 has to be taken. After this surgery, about 90% of the patients will do well, but still 10% patients can have recurrence if the tumor has already metastasized by the time of surgery. Now, if the patient has presented with clinically evident MTC, what can be done? Now, along with total thyroidectomy, we also will do bilateral central neck dissection. Central lymph node neck dissection will also be done, because these most commonly will have been spread to the surrounding lymph nodes. Now, why is surgery very important and crucial in management of MTC? Because 10-year survival of metastatic medullary thyroid carcinoma is only 20%. Therefore, surgery as soon as possible after the diagnosis has to be done. If the patient is inoperable or there is already metastasis, we can give tyrosine kinase receptor inhibitors like Venditinib. So till now we have discussed the MEN1 syndrome, the associations of MEN1 syndrome, the parathyroid involvement, pancreatic neuroendocrine tumors including gastrinoma, insulinoma, then glucagonoma, VIPoma, and other non-functional PPomas. Then we discussed the anterior pituitary tumors. Then some other manifestations of MEN1 like adrenocortical carcinoma, etc. Now we are discussing MEN2, in which we have discussed MEN2A, MTC only, and MEN2B. And now we are discussing the individual manifestations which are common to MEN2A and MEN2B. First, we have discussed the medullary thyroid carcinoma, which is present in almost 100% of the cases. Now we are going to pheochromocytoma. So pheochromocytoma is a catecholamine secreting tumor which occurs in more than 50% of the patients with both MEN2A and MEN2B. These are the major cause of morbidity and mortality in these syndromes. Now, what are the presentation of this pheochromocytoma? It can either present with symptoms and signs of catecholamine excess like headache, palpitation, sweating, uncontrolled hypertension, or this can be detected through biochemical screening even when the patient is asymptomatic. So based on the family history of MEN2A, MEN2B, if we are doing biochemical testing, we can get a preclinical diagnosis of this pheochromocytoma. Now, what are the special features if this pheochromocytoma is associated with MEN syndrome? So let's discuss the features of sporadic pheo versus that associated with MEN2A and 2B. Firstly, Sporadic pheochromocytoma is usually unilateral, while those associated with MEN2A, 2B is usually bilateral. In sporadic cases, 10% cases have extra adrenal involvement, extra adrenal involvement, while extra adrenal involvement is very rare in pheochromocytoma associated with Mann syndrome. Malignant pheo is also seen in 10% cases of sporadic cases, while it is again rare with MEN2A and MEN2B. So bilateral is common with Mann syndrome, but extra adrenal involvement and malignancy is less commonly associated with MEN2. Now, what investigations can be done for pheo? So, just like other patients of sporadic pheochromocytoma, we go for plasma or urinary metanephrin. So, plasma metanephrin is more sensitive, while urinary metanephrin is more specific test. Then we can go for CT MRI, or we can go for radionuclide scanning. For treatment, the treatment of choice is surgical removal, and during and before the operation, BP has to be controlled. First by giving alpha blocker, then by giving beta blocker. Now this is very important concept, because if we give beta blocker alone in pheochromocytoma, it can lead to unopposed alpha action and patient can land up into hypertensive emergency in the form of stroke, CCF, etc. Finally, parathyroid tumors associated with MEN2. So these are only seen in MEN2A, not seen in MEN2B. Instead of parathyroid tumors, MEN2B have 4 M's, which we have discussed. 10 to 25% patients of MEN2A have parathyroid tumors. But important to note that more than 50% are asymptomatic. There will be no hypercalcemia. Investigation and treatment is similar to those of hyperparathyroidism seen in MEN1 syndrome, and definitive treatment is surgery. Now coming on to the genetics of MEN2. So MEN2 is due to mutation in RET protooncogene. This encodes for tyrosine kinase receptor, and as we know that this tyrosine kinase receptor, insulin acts through this receptor, and all the growth factors like insulin like growth factor, platelet derived growth factor, epidermal growth factor, all the growth factors act via this tyrosine kinase receptor. So this basically leads to unopposed growth. Now in these MEN2 syndromes, the location of mutation will decide the variant of MEN2 syndrome. So in MEN2A, in 85% of the cases, the mutation in RET protooncogene occurs at the 634 position, and there is replacement of cysteine to arginine amino acid. In FMTC, that is medullary thyroid carcinoma only syndrome, in more than 50% of the cases, there is missense mutation which leads to change of cysteine to arginine on 618 position. In MEN2B, in more than 95% cases, on RET protooncogene at the level of 918 position, there is change of methionine to threonine. So this is the importance of genetic testing in identifying the MEN2A variant which syndrome is present. Now who all have to undergo RET mutational analysis? So it must be performed in all patients of MTC with family history of MEN2A, FMTC or MEN2B. It has to be done in all patients with MTC along with pheochromocytoma. So if both of these are present even without family history, we have to go for RET mutational analysis. If there is bilateral pheochromocytoma which is common in MEN2, then we have to go for RET mutational analysis. And even if there is unilateral pheochromocytoma but associated with increased calcitonin levels which can be due to medullary thyroid carcinoma, we go for genetic analysis. How do we follow up patients who are RET mutation positive? We have to do annual follow-up. So for MTC, we can test serum calcitonin and do neck ultrasonography. For pheochromocytoma, we go for urinary or plasma metanephrin. For parathyroid, we go for ionized calcium levels. So this medullary thyroid carcinoma screening has to be started at 1 to 5 years of age. As later the age, more is the chance of metastasis, poor is the prognosis. So this has to be started earlier. While for pheochromocytoma and parathyroid adenomas, we can start screening after 10 years of age, typically at 11 to 16 years of age. Now, after we have discussed MEN1, then MEN2A, MEN2B, a few points on MEN4. So, when the MEN1 tumors, that is 3 Ps, parathyroid, pancreatic neuroendocrine tumors, and anterior pituitary adenomas are associated with additionally gonadal tumors, adrenal tumors, renal tumors, and thyroid tumors, this is considered as MEN4. What is the difference in mutation? In MEN1, there was menin gene mutation which was present on chromosome 11q. In MEN4, there is mutation in CDKN1B gene, which encodes for a 196 amino acid cyclin dependent kinase inhibitor. So this is all about MEN4. So we have discussed all the MEN4 syndromes. Now with the help of this table given in Harrison, we will quickly revise MEN syndromes. So MEN1 is due to menin gene mutation on chromosome number 11q. It is a tumor suppressor gene, and the type of mutation will not change the phenotype in MEN1 as we have seen in MEN2. So the most common manifestation out of the 3 Ps are parathyroid adenoma, which is seen in 90% of the cases. Then second most common is enteropancreatic tumor, which are seen in 30 to 70% of the cases. Out of all enteropancreatic neuroendocrine tumor, most common is gastrinoma, followed by insulinoma. Then we can have non-functioning tumors, glucagonoma, and rarely VIPoma. So with VIPoma, we have to remember WDHA syndrome. Third P is pituitary adenoma, which is seen in 15 to 50%, out of which most common is prolactinoma. We have seen how it can present in females as well as in males. Then second most common is growth hormone secreting somatotrophinoma. Then rarely it can be ACTH or non-functioning adenoma. All these can although lead to mass effect as well as stalk effect. So both functional as well as non-functional tumors can lead to mass effect as well as stalk effect. Now associated tumors which are usually non-functional, these are adrenocortical tumor, pheochromocytoma rarely in less than 1% of the cases. Then carcinoid tumor, which can be bronchial, thymic, gastric carcinoid. Thymic carcinoid is associated with poor prognosis and male to female ratio is 20:1. Then lipomas, angiofibromas, collagenomas, these help in preclinical diagnosis in patients, especially the family members of MEN1 patients. Now the most common mutation is deletion followed by intron inversion. Now we have discussed MEN2. It is divided into, firstly it is due to mutation in RET proto-oncogene, which encodes for tyrosine kinase receptor, and type of mutation will decide which MEN2 syndrome will occur. So MEN2A, MEN2B and MTC only. MEN2A have triad of MTC, pheochromocytoma and parathyroid adenoma. Most common is MTC, which is seen in about 100% of the cases. Now instead of parathyroid adenoma, the MEN2B will have associated abnormalities in the form of 4Ms, mucosal neuroma, Marfanoid habitis, medullary coordinated nerve fibers and megacolon. Then there is MTC only syndrome, in which there will be only medullary thyroid carcinoma in the family members associated with this RET proto-oncogene. So we have discussed the various mutations associated with MEN2A, MEN2B and MTC only. Finally MEN4, if the features of MEN1 along with testicular tumor, ovarian tumor, adrenal and renal tumors are present, this is considered as MEN4. The gene is on the 12th P chromosome, and what is the gene? CDKN1B, and no common mutations are identified for this. So with this we have discussed all the MEN syndromes. For MEON syndromes, I will make a separate lecture. Now let's discuss, are we able to solve the 3 questions which we have seen in the beginning of the presentation. So first question was most common pituitary adenoma associated with MEN1. So pituitary adenomas are present firstly in 15 to 50% of the cases. out of which most common is prolactinoma, followed by growth hormone secreting adenoma, followed by ACTH, then non-functional are also rare, less than 5%. So the correct answer will be prolactinoma. Second question was 32-year-old male presents with OPD of complaints of weakness, headache, sweating, fainting. This is due to hypoglycemia, improved after food intake, history of MEN1 running in family, serum C-peptide levels are found to be elevated. So what is the definitive treatment of choice in the patient? So we are dealing with a patient with insulinoma, which is a pancreatic neuroendocrine tumor associated with MEN1. So medical management includes octreotide, dioxide, and frequent consumption of carbohydrate rich meals. But as we have discussed, surgery is the treatment of choice in all the pancreatic neuroendocrine tumors. So surgery will be the answer. The definitive treatment will be surgery. Finally, last question. If there is parathyroid adenoma associated with testicular tumor, this will support the diagnosis of MEN4. And in question, we are also getting CDKN1B gene mutation. So the answer will be MEN4. So this was all about this lecture, guys. Thank you so much.